All right, as many of you probably know, hopefully most of you, we have an exam coming up a week from today. There will be a midterm review this coming Friday, 10 to 11, in Science Center C. This is optional but recommended. It will be videotaped, so if you can't make it, you can watch it online. It's totally question and answer. The way we'll do it is that if you show up, your question will get priority. After that, anyone who emails me questions, we'll answer them until we run out of time. But if you want your question answered, then please show up. If you have any questions, you can email me. And Professor Christakis will talk more about the format of the exam. Thanks.
Okay, can you hear me? Yeah? So, a couple things. First of all, today we won't have office hours. I'm sorry. I have to do some stuff at Forsheimer House related to a guest we have. The midterm exam, we posted all the exams from the last 8 years. Both the midterms and the finals have been posted now, both on the course iSite and on my website, nicholaschristakis.net. If you go to SOC 190 and click FAQ and you go down, you'll see all the links. So very easy to access all the past exams going back years and years. In terms of the format this year, what we're going to do is we're going to do something a little different, very slightly different. We used to give one essay. It would give you like 2 or 3 essay questions. You'd pick one, and then we'd give 6 or 8 short answers, and you'd pick 3 or 4 or something. This time we're going to do something different because the class is so big, it's just not feasible for us to grade essay questions that are handwritten for this many people in this short a time. So for the final, we're going to keep that because you type those. So instead, we're going to give sort of 5 short answers, and they're not going to be quite as trivial as the previous year. So if you look at previous year's exams, they were extremely short, like, do you or do you not know this little fact? You know, what are the 3 ways you might define illness? And then you would name them and give a brief example, and that would be it. So this year it would be a little bit more than that, but not full essay questions. So like an exam book page worth. And we'll give you 6 questions, pick 5, okay? So the midterm will consist of 5 questions. Each will count for 20 points. You'll give you some limited amount of choice. And we've put all previous exams up online. Any questions about those mechanics in terms of the exam? Which is next Wednesday. Next Wednesday. Yeah, in the back.
1 hour, correct?
Yeah, 1 hour, and it's Harvard time. It's so hard to. Please be seated. I mean, we will distribute the exam promptly at 7 minutes after. We're not going to wait for. If you come in late, well, then you'll start late, and then it ends smack at on time. Yeah. Yeah. Yes, the midterm review will be filmed. But the thing is that this is a tragedy of the commons. If nobody shows up to the review, the filming will consist of Gabe sitting there and looking at the camera. So the whole point is don't hope that your friends will go there and ask interesting questions and then you'll just log on at your leisure. Plus, you don't learn as much, right? I mean, I like giving lectures, but believe it or not, I love going to lectures. Now, maybe that's just because I'm a crazy academic, but there's something about the realism and the experience of being in a lecture where you pay more attention. And similarly, when you go and you talk to a person and ask questions. So yeah, show up if you want. Anything else on the logistics? Any other questions more generally? We're kind of well into the course now. Okay. So last time we reviewed different ways of defining disease, and we talked especially about the normative standard and social construction of illness and health. And I want to remind everyone again that there's some confusion sometimes to the terminology. The normality standard refers to a normal distribution and is the statistical standard, like a normal distribution. The normative standard refers to norms or prescribed rules, and that's the social construction standard, the normative standard. And medicalization is not the same thing as social construction either. Social construction is a more neutral term, sort of less pejorative. It just refers to the way in which knowledge is made and not found, and also is much broader, right? I mean, the ideas of social construction are used not just in medicine, but in many other disciplines. And we examined these ideas of social construction, in particular through the lens of female reproduction, and we saw how a natural birth movement emerged in the 80s and 90s, and how, while quite understandable, the situation is actually a bit more complicated than that, in that the burden of mortality in natural circumstances can be unacceptably high. And we saw how our ideas about what is and is not a disease inform our responses to it, what actions we take, and our further creation of knowledge, and indeed our perception of the world. Now, I made a mistake which was brought up to me in rushing through the beginning of the lecture last time when I was talking about the language stuff. I misspoke and I described the results as the opposite of what they actually are. This is not something you need to know necessarily for the class. Remember, I opened the class with a series of examples to set the stage for the claim that when we look at women's bodies, it might be in a similar kind of vein. So here, remember, the point is that the average total savings rate on the y-axis varied across these countries, and the question was, to what extent did they vary according to whether or not the language had a future time reference or not? And languages that were roughly dichotomized into languages in which made a distinction in their verbs between the future and the present, and languages which did not. And in fact, it's languages which do not make a distinction that have the higher savings rates, not the opposite. So languages that do not make the distinction have the higher savings rate. And the intuition behind it is, if you think that your future self is a different self, this is an idea we'll come back to at the end of lecture today if time permits. If you think that your future self is someone else, it's not you, then you might be saying, well, to hell with that person. I'm not going to save any money for his retirement. That's a different person. That's not me. But if you don't divide the future and the present in this way, if you're not sort of, accustomed to thinking about the future and the present as distinct, but rather as the same, perhaps the argument goes because that's the way your language is constructed, you might say, well, the future self is the current self. Better save, better take care of this guy, better not smoke, better eat right, and so forth, okay? So the argument the authors were making in this paper is that the verbs, the linguistic constructions, frame your mind to think about your future self differently if the verbs do not distinguish the future from the present than if the verbs do. Is that clear? Okay. So today we're going to be shifting gears and we're going to be talking about the experience of death and dying. And it's going to be a rather more somber session today. And it's fashionable to speak about vulnerable populations. And we've already begun to think about people who have less education, people who live in different parts of the country or the world, different racial minorities, for example. And it's very fashionable to speak about vulnerable populations in medicine. But to my eye, there can be no more vulnerable a population than those among us who are terminally ill. That group of people, that class, cannot sort of band together and vote at the next election. They won't be alive at the next election. And they can't assemble in the streets and march on Washington to complain about the quality of end-of-life care because they're in bed and they're dying. And I think we as a society have, generally speaking, neglected the interests of this class of people, those among us who are seriously ill and dying. So the typical trajectory of a person who is seriously ill, so who dies in our society and what does death look like? So typically, there's the onset of the illness at some point in your life, and 75% of people who die typically die after having had a chronic illness. So most of us don't die suddenly. Most of us die from things that we've had for a long time before we ultimately die. And we've had many years of illness, of experiencing the illness and being treated for the illness up until that point. And at some point in our lives, we enter a terminal phase of the illness, which typically lasts between 2 and 12 months. And this phase is characterized by kind of gradual decline, but this depends on the diagnosis. So different diagnoses have different shapes to the decline curve as you approach death. Pain is a common symptom of people near the end of life, but actually so are many other symptoms. And most of you probably think of painfulness of death as being the crucial symptom. But actually, having cared for many, many people near the end of their lives, I can tell you that non-pain symptoms are often much more distressing to patients. For example, shortness of breath or dyspnea, which afflicts about 50% of people near the end of life. People in pain will tell you they hate the shortness of breath, but can tolerate the pain. Okay? So imagine if you were suffocating all the time, every moment of every day. That's an oppressive symptom, which is extremely distressing to patients. Or they can have other symptoms too, like fatigue or depression or itching. I mean, people have committed suicide from itching, much more so perhaps even than pain. So people have a number of symptoms that sort of begin to plague them near the end of the life. Some of them are very unsexy symptoms like constipation, which can also be very distressing and not as easy to treat. One of the great ironies is that it's much easier to treat pain than non-pain symptoms near the end of life. And then they enter sort of the final phase of their life, and the last week of life typically involves a kind of shutting down of the body, of the body and the mind, and actually the kind of social connections that a patient has. And they progressively sort of, evince a kind of disconnection from their body, from the world. They kind of begin to let go, as it were. And typically about half the time, patients go into a coma in the very last day or two of their life, and then within 24 to 48 hours of the onset of coma, people die. And they go psychologically through, the well-known kind of Kubler-Ross responses to terminal illness: denial, anger, bargaining, depression, and acceptance. But they don't necessarily go in that sequence. They don't necessarily go through each one of them. They can go round and round. It's not monotonic. It's not linear. But most patients evince some aspect of those denial, anger, bargaining, depression, and acceptance. But typically there's hope in all stages. And this is the other thing that's so difficult and challenging about taking care of terminally ill people. And when I haven't in a while, but when I used to train medical students in how to care, and house officers, and how to care for people who are dying, I would often talk to them give them tips on how to talk to someone who's dying. And probably most of you, when I say that, think to yourselves, gee, how can I do that? What do you say to a dying person? And typically what I'll say is, well, a very reasonable thing to ask a dying person is, tell me what your days are like now. And anyone can answer that question, and a dying person will give you a rather interesting answer. Or you can say to them, tell me a little bit about your hopes and dreams. And what's amazing to me is that most medical students freeze up and say, how can I ask a dying person what their hopes and dreams are? And to which my answer is almost inevitably, what makes you think a dying person doesn't have hopes and dreams? I mean, they're human. Of course they have hopes and dreams. And usually that opens up a very interesting conversation with a person near the end of life. Now, some fraction of the time it opens up an extremely difficult conversation in which the person will say something like, I hope that there'll be a miracle, and that I'll be cured. And that is a dicey and difficult thing, which you don't have time to talk about how to handle that today, but there are books on this. There's a wonderful book called How to Break Bad News, if you're interested. Actually, that book could be used in breaking all kinds of bad news, not just medical bad news. Like, it works for, ditching your boyfriend and your girlfriend too, actually. And the dying have a number of concerns when you talk to them about, what are your hopes and dreams? And they have a number of concerns. A lot of them will talk about how they have this sense that the world is going to continue even without them, which can be very distressing or pleasing to them. They're very, very worried about their families. Almost always when I would talk to people, their main concerns was, how will my wife do after I'm dead? How will this affect my children? And so forth. They have some fears, some existential and theological concerns. I've often been asked, what I think happens after I die, and I tell them I don't have any special insight into this, although I've seen many, many, many people die. But it's a very common question. Many of them are very poignantly afraid that dying will be something not like nothingness, but like loneliness. And so, on this, without any evidence whatsoever, I reassure them. And they can express anger at their bodies. People are very angry at their decrepit bodies near the end of their life, and so forth. And what's astonishing to me is that people in our society have bad deaths, despite the fact that we spend so much money on medical care, and despite the fact that most of them are actually under the care of professional doctors and nurses. So let me see if I can give you a visual picture of what a dying person looks like, something that most of you probably have not experienced, because the death among us is not a common experience in modern life. It's usually far removed from our everyday experience. This is a woman a few years before she died. And this is what it looks like after the onset of her illness, but still more than a year before her death. And you can see that illness is extremely aging and exhausting, right? I mean, this couple looks exhausted. And here is what she is like now, much closer to her death. Look at her poor husband, who's going to miss her so much. And I'm showing you these pictures to try to give you a feel for what the experience of death in our midst might be like, because right now in this city, there are dozens of people having this exact experience that you're seeing here. Right now, as we're sitting here, people throughout the city are having this experience. And it's often hard for students who are by and large, like you, young and healthy, to get a feeling of the experience of dying. But the dying often have a very different perspective on life than we do. One of my most shocking stories about this was early in my training, when I was a young doctor in training. I spoke to a woman who had more equanimity about her death than any person I've ever, well, with one exception, any person I've ever cared for since then. And I asked her, I said, I was a bit bold. I said, are you afraid of dying? And she said, well, I don't want to die, but I'm not afraid. And, of course, to us, that must seem like a very difficult to understand. Like, how could you be so fearless? And she said to me, Nicholas, she said, what you don't understand is that a dying person wants to die like a sleeping person wants to sleep. She said, you know that feeling when you're utterly exhausted and all you can think about is just collapsing and going to bed right now? She goes, that's what my experience is like. And she said, you cannot understand that because your body is working and fine. But if you had lived through my illness for 20 years, you would have a very different perspective. This is Frank. He's dying of lung cancer at home in rural Pennsylvania. This is within 1 day of his death. He's shown here with his son and his son's wife and their newborn grandson. And what I want you to focus on is not so much the physical appearance of Frank, which is very typical of someone dying of a solid tumor. I don't know whether he had colon cancer or prostate cancer or something else, but this is very typical appearance of someone near the end of life dying of a solid tumor. What instead I want you to focus on is the kind of love in the family, right? And the kind of proximity of all these other people and the kind of connection they're all still making even so near to the end of life. And in fact, people manage death just fine if we provide them with the adequate means to care for their loved ones, if we give them good symptom control and good professional help and support. This is a man with advanced pancreatic cancer and his wife and a very large dog. They died about 6 weeks after this. And notice the fun in the room, right? Dying people are still capable of having fun, right? They're still like you and me. They're still people, even though they are a very special and vulnerable class. Now, getting a feeling for what a good death is and how often it is achieved in our society and what might be done to facilitate this outcome is actually the main focus of what I want to talk about today. And death is primarily a problem of the aged, though not exclusively. So I've already mentioned that 75% of people who die are elderly, and then the near elderly, the next 10%, and then this group. And then your group, your age group, is not common that death strikes your group, and then people who are the very youngest. We spend a lot of money caring for people at the end of life. So the mean amount of money that are spent in the elderly, people older than 65, we spend about $25,000 caring for them in the last year of life, and about $10,000 in the year before that, and $7,000 in the year before that. And the expenditures in the last year of life decline substantially with age at death. So older people use less money near to the end of lives, not surprisingly, than younger people, right? We'll spend a lot of money to try to save a 30-year-old's life in a way we wouldn't to try to save a 90-year-old's life. And the patients also make different choices for themselves. A 90-year-old will have different choices. But they do not vary, the amount of money spent, very much by race and gender in multivariate models. So Americans clearly spend enough money so that you would think that they would be entitled to have terrific terminal care and a good death. And 25% of all healthcare spending by Medicare, which is the main entity that spends money on healthcare in this country, and in general, is spent in the last year of life. Okay, so most of the money we spend caring for people is spent in the last year of life. And what do Americans want for all this money? So one survey of seriously ill patients taken from your reading found numerous attributes of a good death, including those that are listed here. And I'm going to focus on the top 5 today. So you ask Americans, what's a good death? They'll say being free of pain and other symptoms, 93%, not being a burden to family, 89%, having someone who listens, 95%, dying at home in this sample was 35%. In another data set I'll allude to later, in the support study, it's greater than 70%, and knowing what to expect, 96%. And they often articulate other things like being kept clean, having your financial affairs in order, being at peace with God, having your family present, and so forth. None of these should be surprising to you. These are common sense desires that people have about what kind of death that they would like. And so the question is, and we spend a ton of money on this, and the question is, do we achieve this objective? Well, let's look at the top 5 on the list over here. This slide shows pain in conscious patients who are dying in a hospital, okay? And it shows that 50% of Americans have moderate or severe pain at least half the time within the last 3 days of their life. I want you to really think about that statistic. These are our colleagues, our citizens of our wealthy nation, who are in a hospital, an American hospital, getting care, and who are about to die. They're 3 days from death. So really there should be no concern about becoming addicted to drugs or something crazy. And 50% of them are dying in pain. 50% of Americans die in pain. Moreover, 50% of the time, they have other kinds of significant suffering while they're hospitalized. So, for example, 50% of Americans have prolonged suffering defined as a week or more of ICU care, being in a coma, or being on a ventilator near the end of their lives. And actually, the Americans are the luckiest ones. The situation with respect to pain relief near the end of life is much worse in other parts of the world. This slide shows per capita consumption of morphine in 155 countries around the world. On the y-axis is the per capita milligrams per capita of morphine consumption, and then these are 155 countries. Here's Austria, they're big users of morphine. Here's Canada, the United States is like 6 from the top. Here's Italy, very interesting, right around the median. And look at all these countries. Basically, if you die anywhere in the world other than in Europe, you die in agony. So the entire part of the world south of the Sahara has no opioids. Nothing is available to treat these people for pain, which is an inevitable part of life near the end of life. To me, it's just, I don't even know, I can't think of an extreme enough word to describe, like, it's not just a tragedy, I don't know what it is, it's a Holocaust. I mean, it's just unbelievable, actually, that the vast majority of the people on this planet, when they approach the end of their lives, have no relief for their pain whatsoever. And if you look at other things, for example, so 90 to 95% of patients, as we saw at the beginning, want other people, including their doctors, to listen to them near the end of their lives. For example, about the nature of the care that they would want to receive. But this so-called support study, one of the other studies I'm alluding to, a very famous study that cost about $30 million, looked at 10,000 patients dying of 6 different conditions at hospitals around the country and followed them over time. This so-called support study found that 53% of the time, these patients who were dying and were in American hospitals had a physician who did not understand that the patient wanted to avoid CPR. So they asked the patient, would you like CPR if your heart were to stop? And the patient says, no, I don't want it. And then they go ask the doctor, what would your patient want if their heart were to stop? And the patient, the doctor, they would want to CPR, or vice versa. So the doctors did not know what the patients wanted, even though the patients are seriously ill and in our hospitals. And 70% of the time, physicians did not discuss CPR with seriously ill hospitalized patients. So you might think, perhaps watching television, that there are these very dramatic conversations that doctors have with patients about what they might want. Alas, that's not, in fact, what happens. Well, what about where people die and why they die? What determines the place of death for Americans? Is it something to do with patient preferences? Well, most people, as we saw, said they would prefer to die at home. But unfortunately, very few patients are able to realize their preference, and home death is very uncommon. So 55 to 60% of Americans die in hospitals, 20 to 25% in nursing homes, 15 to 20% at home. This includes hospice care, incidentally. And actually, this is artificially inflated because if you drop dead at home, we count you as a home death. I mean, that's hardly like a credit to our healthcare system, that you've achieved your objective, but only by virtue of collapsing in your own home before, you could be whisked away to the hospital. And 0 to 5% die in other venues. People always ask me what that is. Things like prisons, for example, which is obviously not where anyone would like to die, or public parks, or airports, or things like that. But the question is, the support study showed that there was no relationship between a patient's preferences for dying at home and whether they were able to do so. So here is the percent of patients dying in a hospital according to what the patient said was their preference for dying at home. So patients were asked, this prospective cohort were asked, what would you like to do? Would you like to die at home? Would you like to die in a hospital? Where would you like to die? Everyone was asked. And then they followed the patients forward and saw where they did die. And so of those patients who said they very much would like to die at home, 57% died in the hospital. These are patients who say, I want to die at home. They're in our country where we spend so much money and we have such a conviction that individual liberty and self-determination is important. Nevertheless, 57% of them die in the hospital. That's the first point. The second point on this slide is it didn't seem to matter. By and large, there was not much of a relationship. No matter what you wanted, you don't want to die at home, a little bit, moderately, quite a bit, it doesn't matter. About half of you wind up dying in the hospital. So there's a lack of respect of patient wishes. Keep in mind, I'm not saying that everyone should die at home, nor am I saying that I think, that I know what's right and people should die at home because I'm specifying that's best. I'm saying that what I really want is a healthcare system that delivers to patients what they want. So if you say you want to die at home, we give you that. If you say you want to die in a nursing home, we give you that. If you say you want to die in a hospital, we give you that. If you say you want to die in a park, we give you that, okay? So we give people what they want is what I'm advocating for. So patient preference for home versus hospital death did not seem to influence whether the patient died in a hospital or at home very much at all. However, one thing that did help a patient die at home is hospice care. Now, hospice care, I need to emphasize, in our country is not a building. So most hospice care in our society is home-based care. Okay, so if you think about hospices as like a building you go to, in fact, that's a tiny minority of hospice care in our country. Actually, what hospice care is the following. It's a mode of terminal care that emphasizes palliation and relief of a patient's physical, emotional, and spiritual pain and suffering rather than the treatment of the patient's underlying disease. Hospice care neither hastens nor delays death. Please remember this when you get into arguments with your relatives and other people. It does not shorten your life. In fact, there's some evidence that hospice care lengthens your life. It is the active total care of patients whose disease is not responsive to curative treatment. So hospice care does not mean doing nothing. I'm going to aggressively palliate your pain. I'm going to make sure you have no symptoms. It's not an easy thing to do, but I'm going to full court press do that. Hospice care is not sit on my hands and do nothing for the patient. And the goal of such palliative care is the achievement of the best quality of life for patients and their families. And in the United States, hospice care is multidisciplinary and primarily outpatient, which can be contrasted with the kind of more inpatient focus of British hospice care where it originated. And it has numerous documented advantages. It's home-based, it provides for superior management of pain and non-pain symptoms compared to hospital-based care, and it's associated with higher patient satisfaction. And overall in our society nowadays, about 30% of elderly decedents, people who die, use care use hospice care near the end of their lives, and something like 65% of elderly cancer patients actually get hospice care. Although only about a third of Americans die of cancer, so the non-cancer cases get hospice care in much lower percentages. And indeed, two predictors of whether a patient died at home were factors unrelated to patient preferences. So here we are again, structure versus agency. Is the patient's agency, what they want, being recognized, or is there something outside the patient, some structural factor that helps determine whether the patient is able to achieve the objective they have? And studies have shown that hospice spending is such a factor. So each additional $10 that is spent per elderly Medicare beneficiary on hospice care yields a 2.8% decrease in hospital death. So if we spend more money providing for hospice services, people are less likely to die in hospitals. And the regional bed supply of hospital beds also is a factor. Each additional hospital bed per 1,000 elderly Medicare beneficiaries yields a 5% increase in hospital death. So if you build hospitals and they're full of empty beds, those beds are like a giant sucking sound. Like they just vacuum up everyone in the community that is going to die and goes into the beds. But if you provide for hospice services, you have a different kind of system in place. And this slide shows geographic, so-called small area variation in the United States. Here the United States has been divided into 306 so-called hospital referral regions, these geographic regions. And the slide shows the percentage of patients dying in a hospital by these hospital referral regions. So it's colored according to the percent of Medicare deaths that are occurring in hospitals. So the dark blue ones are 40% or more of the deaths occur in hospitals. And deaths could also occur in nursing homes and other locations in these populations. And you can see like Mississippi just lights up, like everyone in Mississippi goes to a hospital to die. And much of Texas and other parts of the country as well have hot spots. And the point is not the particular parts of the country which evince hospital death or not. The point is that there's this geographic variation. Whether you die in a hospital will seem to depend on the artifact of whether you are living in one part of the country or another part of the country. The small area variation where you live determines what kind of care you get near the end of life. That's the first point. And the second point is that you can look at these studies and these small area variation studies, they can provide a kind of aspirational function. Let's say you're a policymaker and you're saying, I'd like to design policies that actually meet Americans' needs for dying at home. And you say to yourself, gee, I wonder what kind of success could I have? If I designed a fantastic policy, what could I hope to achieve? Well, if you look at a map like this and you see some regions of the country are able to achieve what you want to achieve, that can serve as a target for you. Or if you see that side by side there are two areas with very different cultures or very different fractions of patients getting care in hospitals or home care, for example, then you can say, well, what's different about these places? How can I gain insight into how I might design policy to meet the needs of the populace much better? And this again illustrates the classic issue of structure versus agency, the classic sociological concern with a societal influence on people's life chances. And let's turn now to yet another aspect of good death that we mentioned at the beginning. Remember, 89% of Americans rated not burdening their family members as a key aspect of good terminal care. But unfortunately, a majority of Americans went on to have deaths that were quite burdensome. 55% of families had at least one of the following effects. So needed large amounts of family caregiving, 34%. A major life change for a family member, 20%. Other family illness from stress, 12%. Lost most of family savings, 31%. Listen to this, guys. A third of Americans lose all or most of their life savings in caring for the first person to die in the family. Families are impoverished by death in our society, right? Caring for the first person, and that leaves no money to care for all the other people who also are going to die, right? We're all going to die. So, all of the money is lost in caring for the first person. Lost a major source of income, 29%. Major change in family plans, 55% of families have at least one of the above occurrences. And finally, let's take a look at prognosis, something I spent a lot of time studying at the beginning part of my career, and I wrote a book called Death Foretold, Prophecy and Prognosis in Medical Care, from which this quote is taken. This was a patient that I was taking care of when I was a hospice doctor in Chicago, and the patient said to me, "How long will it be, doc? I can deal with the physical part of caring for my dad," and her dad was dying of renal failure, "but I just want to know. I watch him breathe, and with every breath I wonder if that will be his last. The nurse said, we can't say how long it will be, but I want to know because it hurts me to see him like this, and I don't want to see him like this. Is he going to linger or get worse? What is going to happen? And I want to be with him as much as possible, and I want to be there when he dies. I don't want to miss that." Now, this patient's daughter rightly believes that a doctor should be able to provide her prognostic information. And she wants this information not because she just has this idle curiosity, but she wants it for two very important and material reasons. First, her father is suffering, and she wants to know when will the remission of this suffering come. And second, she has tactical problems. She's afraid that if she leaves the house to go and do the dry cleaning or pick up the groceries, that's when dad is going to die. So she's trapped at the bedside for weeks, fearful of going out. So she has, in my judgment, every rightful expectation that the healthcare system would be organized so as to be able to formulate a reliable prognosis and communicate a reliable prognosis to her. And in fact, larger, more formal, quantitative studies support the salience of prognosis in patients' minds. Again and again, surveys of patients document that they rate prognosis as the number one piece of information they want from their physicians. Actually, if you think about when you go to the doctor, you're not really so interested, maybe you are, but mostly you're not, in the anatomy of your shoulder injury or the physiology of your asthma. What you want to know is, what does it mean for your life? When will it stop? When will you get better? Okay? And you're not interested so much in the pharmacology of the treatments. You're interested in what the treatments can do for your future. How can they affect the course of a disease? So the question arises now, are doctors in fact able to formulate and communicate a reliable prognosis, one that both patients and doctors could then use to act on? Here's a study we did a few years ago, published in the British Medical Journal. What we did is we impaneled a sample of about 500 seriously ill patients who were being cared for by their own doctors and were dying under a home hospice program at Chicago. And we asked the doctors to tell us, not what they told the patient, tell us how long do you think the patient has to live? 1, 2, 3, 4, 5, 7, 14, 30, 90 days or so forth. Make a prediction to us. And then we follow the patient forward to see how long the patient did live. So if the doctor predicted the patient would live 90 days and the patient did live 90 days, you'd get a spot right smack on the diagonal. And the first thing to notice is that there are not too many points on or even near the diagonal. These are all patients that the doctor thought would live 180 days, 6 months, and every one of them died within a week. The doctors are trying hard to think about how long the patient has to live, and their estimates are grossly in error. First point. Second point, the errors are not random. If the doctors were erring at random, sometimes by dumb luck simply underestimating survival, sometimes by dumb luck simply overestimating survival, you'd have about as many points above the line as below the line. But that's not what you have. Most of the points are above the line. Doctors systematically overestimate survival of patients. This is not what they're telling patients. This is in their own minds, in their formulated prognoses, by a factor of about 5. And as a result of these misestimation, this is not just like an idle little fact or like a kind of incidental feature of the healthcare system. Because doctors have this optimistic miscalibration and bias in the error in the prognoses that they formulate, it leads them to make take other kinds of actions which harm patients. For example, if I wrongly think you're going to live a year, but actually you're going to live 2 days, I might not ask you about your CPR preferences. I think, oh, I've got plenty of time to do that. Bang, you die 2 days later. And then you get CPR, which you didn't want, okay? Or if I think you're going to live a year, but you're only going to live a month, I might recommend all kinds of expensive and painful treatments, which have no hope of helping you because you're actually about to die. But I wrongly have fooled myself into thinking you have a very long survival horizon. So these prognostic miscalibration has consequences for the care that doctors deliver to patients. Now, this type of error is actually fairly widely understood in many societies around the world. I'm told there's a Spanish joke which says, it is better to be told you have 6 months to live by a doctor than by a judge. And I think, that captures the understanding that doctors are often in error when it comes to prognostication. Now, as part of this same study, we also asked the doctors, what did you tell the patient? So you told us the patient had a month to live or 6 months to live. We watched how long the patient had to live. Now we also asked them, what did you tell the patient? And here we plot 3 survival curves. On the y-axis is the percent surviving, and on the x-axis is time. And the solid line on the far left shows the actual survival of patients. So on day 1, 100% are alive, and then they die very rapidly. The median survival is about 30 days here. There's 50% survive about 30 days. And then you have this sort of longish tail here. 5% or 4% live about a year in this population. Now, shifted up and to the right is the survival that would have been observed if the patients lived as long as the doctor's formulated prognosis. So this dotted yellow line here is the survival that would have been observed if the patients lived as long as the doctor thought the patient would live. And then shifted up and to the right again, and that's about, actual survival is about 30 days, median formulated prognosis is about 75 days, and shifted up and to the right still more is the survival that would have been observed if the patients lived as long as the doctor communicated. And the median there is about 90 days. Now, there are 2 points to this slide. First, that the patients become twice removed from the reality of their condition. First, because of unknowing, unconscious errors in the prognoses that doctors formulate. And second, because of additional conscious, knowing errors in the prognoses that doctors communicate. So we might forgive the doctors for being optimistically miscalibrated in their own minds. They didn't know they were in error. But what's our explanation for why they think the patient has 75 days? And I say, what would you tell the patient? So how long do you think the patient has to live? As known to God, the patient has a week to live. I asked the doctor, how long do you think the patient has to live? I think the patient has a month. What did you tell the patient? Oh, I told them 6 months. What possible explanation is there for that kind of dissembling to the patients? So the first point is the patients become twice removed from the reality of their condition. First, because of the unknowing, unconscious errors in the formulated prognosis. Second, because of the conscious, knowing errors in the communicated prognosis. First point. Second, most of the problem is not that the doctors are lying to the patients. It's not that the doctors are telling the patients something different than what they think. Most of the mistakes occur because the doctors themselves are deluded. The doctors themselves are unaware of what's happening. This step from 30 to 75 is bigger than the next step from 75 to 90. So if we're going to fix this problem, we need to begin to think about how we can change the healthcare system to improve the capacity of physicians to formulate reliable prognoses. So here again are the top 5 items that the great majority of people think are key parts of end-of-life care. So here's our report card on how we're doing in the United States when it comes to caring for people near the end of life. So this is taken from your readings, the percent of patients agreeing that these are very important. And here's the percent of Americans that are able to achieve these objectives. Frankly, guys, we suck. I mean, we are just doing a terrible job in taking care of terminally ill people in our society. So 93% think that being free of pain is important. Less than half of Americans are able to achieve this objective. 89 don't want to be a burden to family. Only 45% are able to have a death that doesn't burden their family members. 95% want a doctor who listens, as we just saw. 95% want a doctor who listens. Only 30 to 45% of them have a doctor who knows about what it is, what kind of care they want at the end of life. 70% want to die at home. Only 15% are able to. Most Americans want to know what to expect, but actually, I didn't summarize those results from the previous prognosis slides, but only about 15% of patients are actually given a reliable, accurate prognosis. Only a tiny fraction of Americans have this outcome. So, and these problems persist in our society, despite the fact that we spend $70 billion every year caring for people in the last year of life. Now more than that, probably closer to $100 billion. And despite the fact that every one of us is eventually going to experience this outcome. This is a real interesting problem in the provision of public goods, or a sort of welfare economics problem. Like, why aren't we doing better with this? It's not some marginal group over there who has they're going to die, but we're not. So why should I pay my tax dollars to them? We're all in the same boat together, right? I mean, you would think we would all have a stake in improving care at the end of life. Nor is the problem that we're spending no money. We're actually spending a lot. It's just not being efficiently allocated, in my judgment. So we may conclude that the quality of death in America is poor, that this poor quality varies in discernible ways, and that improving care of the dying is not going to be easy. Well, what can be done? What are some things that we might be able to do? Well, we could begin to think about processes or policies that might enhance communication between patients and doctors. For example, programs that lead to so-called activated patients, where you educate patients before they seek health care in a way that empowers them to speak to their doctors and demand the kind of care that they want. Or we could make changes in medical education. Many of you will go on to be doctors, and I hope you'll have exposure to some of these ideas during your training. Or another kind of thing we might do is investigate the optimal nature and timing of transitions between care systems. It turns out many of the problems with our healthcare system have to do with the handoffs, when the patient leaves the hospital to go to the nursing home, or the patient is discharged from the hospital to go home, or the patient's at home and has to come back to the hospital. So there are these awkward transitions, and a lot of the problems arise there. We can evaluate the role of the specialty of palliative care. Maybe if we spend more money on specialists, more training people who know about this discipline, we do a better job. We can develop the science of prognostication. You know, we have all kinds of statistical tools at our disposal now to perfect our ability to make predictions. And we can design systems of care that address patient preferences. For example, we saw the example of hospice spending. There's another example where there was a radical change about 10 years ago, where in addition to little charts at the foot of a patient's bed that measured their temperature, heart rate, respiratory rate, and blood pressure, they just added pain. So all the nurses in the nation suddenly started asking the patient, can you rate your pain on a scale of 1 to 10, and wrote the number down. Now imagine what it means to write 8 3 times a day and not do anything about it. Or imagine if you're a doctor and you walk in and you look at the vital signs and you say, my God, this patient's been in pain. How long? A week. You know, it's very hard. And then you can treat the pain and see the number go down, right? So giving that kind of servo feedback loop affects how doctors deliver care. Or there are other things we'll talk about in 1 or 2 lectures on harm reduction strategies, how we can arrange the healthcare system to reduce the harm that we cause to patients. So, and we saw in the readings, many of the things patients say are important are ones that doctors do not feel are important. So one of the problems is a mismatch between patient expectations and doctor expectations. And something, in my judgment, needs to be done about our priorities. And in fact, I think listening to patients is one of the key aspects of the redesign of our system for providing care at the end of life. Now, there's one final topic I want to discuss with you, and that's this. So I just said to you, we need to listen to patients. But the problem becomes, which patients? And listen to them in what way? So many or most patients often cannot decide for themselves what should happen near the end of life. For example, because they're unconscious. So most patients, remember I told you at the beginning what the typical trajectory towards the end of life is. You can't ask a comatose patient what kind of care they would like to get. And so if they're unconscious or they can't speak for themselves, they have dementia or they're babies, or they're developmentally delayed, there's some reason we can't elicit from the patient their preference, someone else has to speak for the patient. And the question is, who should that be? Should it be the doctor? Should it be the family? Or maybe a patient at an earlier point in their life. 3 candidate ideas for who should speak for patients if the patients can't speak for themselves. And this is not trivial because, as we saw, 50% of patients are in no shape at the end of life to make their wishes known. And as we also saw, 53% of patients have physicians who are unaware of their preferences, for example, regarding CPR. Well, one idea that's been proposed is substituted judgment. And the idea is, well, maybe we'll ask the doctors or someone else. Maybe the patient's doctor will know or the patient's family member will know. And so here is a study that was published 20 years ago now that looked at the primary care doctors, and it asked couplets. It took patients and their doctors, and they read to the patient a scenario in which the patient was in current health or the patient was demented, and then they suffered some kind of serious illness which might or might not require them to have CPR, okay? And each of those couplets, the patient and the doctor were asked, would you want CPR or not? Would you not want to have a do not resuscitate order? That's what the patient was asked, and that was what the doctor was asked. And if you look at these situations, I think there were 70 total couplets here. 20 of the 70, there was discordant opinion. The doctor thought the patient wanted CPR, and the patient did want CPR, or the doctor thought the patient was DNR, but actually the patient said, no, I'd like to be resuscitated. 14 of them in that situation. And in the dementia scenario, it gets even worse, the disagreement between the doctors and the patients. So you get significant amount of cases that are in the off-diagonal elements, a kind of mismatch between the doctors and the patients. And in fact, when you look at this study and you analyze the data, the doctors did no better than chance alone. The doctors were about as good as flipping a coin in deciding what the patients would want. And it turns out that family surrogates did somewhat better, but they're still far from perfect, especially in forecasted states of serious illness. So the family members are better. They're fewer off-diagonal in the current health scenario, but in the dementia scenario, they're still not doing so well. The diagonal elements being where there's a matchup between the two. Well, if doctors and family members are lousy proxies, how about patients themselves as a proxy? Unfortunately, it's possible that patients' own preferences are not stable or consistent, and that the test-retest reliability of people's preferences is no better than that of the patient or proxy pairs themselves. So the question is here, well, we can't ask the doctors what they want, what the patients would want, and we can't ask the patient's family what they would want. Maybe we should ask the patients much earlier in the course of their illness what they would want should something happen to them. And this is known as an Odysseus contract, modeled after the famous story of Odysseus, who told his men to tie him to the mast as they sailed by the sirens, and all of them plugged wax into their ears, and he told the men, if I hear the beautiful sirens coming now and they're singing, if you see me begging you to untie the ropes, just tie the ropes tighter. And look, the man he's becoming deranged. You know, the song is so beautiful, and he wants so much to go to the sirens, but the men row on. And so Odysseus is the only one who has ever heard the song of the sirens and lived to tell the tale. But the idea is that Odysseus binds his future self. Odysseus says, no matter what I tell you in the future, no matter what I say, untie me, ignore my instructions, obey what I tell you now, not what I say in the future. But this actually raises a more general theoretical problem, and that is the relationship between your present self and your future self. Is your present self an accurate forecaster of your future self? And we saw at the beginning, I think I said in an earlier lecture, I told you the story of that person, that friend of mine, who was born without an arm. People assign different utilities to these different states. So for example, a person with 2 arms may think it is a much worse handicap to have just 1 arm than a person with 1 arm. So how can we know how we would feel about being in the future 1-armed state? Right now, if I say to you, what would it mean if I took away one of your arms? You might think it was a complete disaster. But in the future, when you are in that state, you might not think it's such a disaster. So whose judgment about what it means to be in a 1-armed state do I take? Your judgment or your future 1-armed self-judgment? And the end-of-life equivalent for the Odysseus contract is, of course, the so-called advance directive, where right now you specify in an advance directive what should be done on your behalf in the future. But in fact, people do not appear to estimate how they would find possible states they might find themselves in the future very reliably. So there are different kinds of states. The situations that might befall you, your kidneys might fail and you might need to be in dialysis, which means that 3 days a week you would go to a local facility, and these facilities are all over the country in malls and everywhere else, and you would sit there for 3 or 4 hours, and they would connect you to this machine and through a device in your hand and dialyze your blood. And if we ask people who don't have dialysis, how bad would it be to be on dialysis on a 0 to 1 scale, they give that utility state as being a 0.39, but patients give it a 0.56. Or if I asked you, what would it mean if I had to remove the final part of your colon down to your anus, and then I would bring up that loop of bowel to your abdominal cavity and connect it now to a pouch. So basically you would defecate into this pouch for the rest of your life. Okay, so you wouldn't defecate normally anymore. It would come out of the pouch, let's say because you had cancer in your rectum. And I asked, well, how bad would that be? Non-patients think that sucks. They would give it a utility of 0.8, but patients don't think it's so bad. They give it a utility of 0.92. So if you told me you would rather die than have a colostomy, you're probably making an inaccurate prediction of what your future self would want. And in fact, part of the reason for this is that people have what is known as, described by Danny Kahneman and other psychologists, as a focusing illusion. So when I ask you to imagine this future state, you're immediately focusing on the part of having a bag full of shit on your belly. But actually, there are many other aspects of your life which wouldn't change at all, like your ability to go out dancing or to eat food or to be happy. So you narrowly focus in on a small part of your life, and as a result miss the opportunity to estimate what your real life experience would be like, a focusing illusion. And another potential explanation is adaptation. So our bodies are wired to detect change in our lives. This morning, raise your hands if you have socks on. Okay, this morning when you put on your socks, raise your hands if you felt your socks going on your body. Raise your hands if you're aware of your socks now, before I started talking about them. You weren't thinking about your socks before I talked about them. Your body is neurologically wired to detect change, but once you have experienced that new state, you no longer experience it as problematic. You adapt to the new state. So, I'll just close then by saying these cases of substituted judgment typically emerge in so-called states worse than death, which we saw earlier as well when we talked about patients' utilities. Here's a list of some states that many people consider worse than death. The way the healthcare system treats vulnerable terminally ill patients is instrumental to whether a patient ultimately has a dignified death. And this is related, finally, to a classic argument advanced by psychologist B.F. Skinner in a famous book called Beyond Freedom and Dignity, his argument being that dignity is not an inherent property of individuals originating within them, but rather dignity is a product of their physical and social environment. The causes, of course, can often be external to the individual. Again, structure versus agency. Indignity originates in the treatment of one person by others. And conversely, and just as assuredly, dignity can depend on the treatment of one person by others. And while this is a general observation, it is especially the case in the end of life. If we are serious about dignity, we should revise the way we care for the dying, not only for the sake of patients, but also for the sake of doctors. For in fact, and for ourselves, because it is undignified for the doctor and for our society to provide such undignified care. Thanks.